once there we go. Once people are in the room and have a critical mass here, we'll start up in just a moment. Yeah, this is great. We've got a lot of people coming in, so we'll give it just a few more minutes, and we'll keep an eye on the attendees list, and we'll get going in a second. So your patience is appreciated. While you're coming in, if you'd like to announce your presence in the chat, let us know who you are, maybe the organization you're working with or representing, and then we can go from there. We'll let everybody say hello to one another this morning as we get going.
And Dominic, we have 125 people and growing. So
right on.
If you'd
Let's
like
give
to
another like 15 seconds and then we'll get moving here. I see that number keeps kind of ticking up. Very nice. Great attendance today. All right. Yeah, and thank you all for putting your names and your organizations or part of the world that you're coming from. Really appreciate it. So good morning, good afternoon, and good evening. If you'll go to the next slide, please, Marcella. So thank you for attending the CAP COVID dashboard webinar. I'm Dominic Shattuck, the Director of Monitoring, Evaluation, and Learning for the Johns Hopkins Center for Communication Programs. If you go to the next slide, please. We're joined today by public health practitioners across multiple fields, all using the dashboard in their work as government officials, NGOs, program designers, and journalists. Before we start our program, I'd like to go over a couple of housekeeping items. So if you'll go to the next slide, please. First, please note that we have simultaneous French and Spanish translations occurring. I'm going to advance the slides to show our French speakers how to access the interpretation channel as an example. You'll see the names of my colleagues on the webinar today who can help with any technical issues, and you can message them directly in the chat if there's anything technical that you need assistance with. Second, please use the chat room to greet your colleagues and introduce yourselves if you haven't already, and let us know the diverse range of countries that are represented today. Third, as the presentations occur, use the Q&A tool at the bottom to submit your questions for the panelists. Some of the questions will be responded to in the Q&A tool, while others we might pull into the open discussion if there's time for that. But please use that tool because it's a nice way to kind of get some quick feedback. Myself and others will be in there trying to respond to some of the questions that come up. If you'll go to the next slide, please. Today, we'll be focusing our discussion on how data from the COVID behaviors dashboard have been used to inform programs around the world. But first, I'd like to make sure you're all aware of the features available on the dashboard. So we'll go to the next slide, please. As most of you know, the dashboard was launched in September. The dashboard covers a variety of COVID-19 topics, including vaccine acceptance, reasons for hesitancy, barriers, and information sources. Data are uploaded twice a month, and users can explore trends over time or disaggregated data by demographic characteristics. So if we go to the next slide, please. There are also several new features. In October, we launched a subnational dashboard. Subnational data are available for 71 countries, and the subnational view allows you to see how behaviors and beliefs vary by state or province. The dashboard also now provides country reports that summarize the key indicators in an exportable PDF. These country reports are updated monthly and can be customized to include national and subnational data. These reports are available in 56 languages. Finally, we've prepared a risk communication and community engagement template presentation to help you. That's the RCCEs, which many of you are familiar with. This template is to help you build and customize presentation using data from the dashboard. You can download it, that PowerPoint presentation, under the resources tab on the COVID behaviors website, covidbehaviors.org website. So if you'll go to the next slide, please. Oops, here's some more information. I'm sorry about that. I didn't realize what extra slide in there. And then we'll move on to our moderator for today's panel is Anton Schneider, somebody who I was not so familiar with, but since COVID, we are in meetings all the time together through the Breakthrough Action Project, which has been nice in learning about how this is evolving from the USAID side. So Anton is the Senior Social and Behavior Change Advisor at USAID's Global Health Bureau Office of Infectious Disease. He's developed and managed behavior change activities across a wide array of health issues and infectious disease outbreaks, including avian influenza, H1N1, Zika, and COVID-19. Anton currently supports SBC activities for USAID's global health security activities. And since the COVID-19 outbreak, he's provided support to missions and implementing partners, including development of guidelines, indicators, and demand-related resources to support recent vaccine rollout. Anton, welcome.
Thanks so much, Dominic. Yeah, I feel like you've become extended family since we've been working on COVID. So good morning, everybody. Good afternoon and good evening. And thanks, Dominic, for the introduction. So as Dominic said, I'm with USAID's Office of Infectious Disease. I'm really proud to be here today and to be part of this COVID Behaviors Dashboard initiative that we're going to share with you today. So now, when we plan and monitor our programs, no matter the health issue, there's nothing more valuable than having relevant and timely behavioral data at our fingertips. But when it comes to outbreak response, time is even more critical. We need data quickly, that's updated regularly and frequently. Now, in the past, we've generally had to choose between good quality data and frequent and timely data. It's been very difficult to get both. In my opinion, the COVID Behaviors Dashboard, and this is why Dominic and I have become fast friends, I think the dashboard has gone a long way to address this challenge, to provide us with high quality, publicly available behavioral data almost continuously in what I would call near real-time updates on a bi-monthly basis. Now, I'm told that since September of 2021, more than 17,000 users from 191 countries have accessed the COVID Behaviors Dashboard. Could be higher by this morning. Some have used it to supplement their COVID-19 research. Others have focused on developing public health messaging or reporting critical information to the public and partner organizations. Here at USAID, we found the dashboard incredibly valuable throughout our COVID team as a way to gain perspective on key behavioral issues related to vaccine uptake and other prevention behaviors disaggregated, by country, by gender, and other variables. So today we're going to hear from 4 professionals who've used and are using the COVID Behaviors Dashboard in their work. Hearing their stories and the ways that they've used this data to share knowledge about the COVID-19 pandemic hopefully can offer valuable information for any one of us hoping to do the same. So thank you to all of our panelists today for offering their insight, and thank you all for attending. Now we've, I think Dominic mentioned this, we've reserved a question and answer session for the end after we've heard from all of our presenters. So as questions come up during each of the presentations, feel free to put them into the Q&A chat box and we'll get to as many of them as possible, either in the chat box or during the session later on. So with that, let me move to our first speaker, Helena Ballester. Helena is a social and behavior change specialist working at UNICEF Eastern and Southern Africa Regional Office, where she supports routine immunization and maternal and neonatal health interventions in 21 countries in the region. She's the chair of the ESSA Credit Demand Technical Working Group, a multi-stakeholder coordination platform supporting country efforts to increase demand and uptake of available COVID-19 vaccines. Helena, welcome. Over to you.
Thank you very much, Anton, for the introduction. Please move the slide. So I just wanted to briefly present the context in which we are working, mainly because since the beginning of the pandemic and when we started receiving vaccines in the continent in Eastern and Southern Africa region, the prevalent narrative around vaccine demand and uptake, it was an assumption that said that the main barrier for uptake was vaccine hesitancy. But there was no data to inform what were actually the drivers for vaccine hesitancy, if vaccine hesitancy was present in the region, and if it was not present, what would be the other barriers that we need to overcome for promoting demand and uptake of COVID-19 vaccines. So we decided to roll out a tool to measure behavioral and social drivers of vaccination called the BESD. And we use several platforms, mainly VRE, but also face-to-face. And many of them, the results, despite them informing our programming, they were not country representative. So we needed to triangulate the data. Next slide, please. The main domains that we are observing is, or areas that we are working with, is the thinking and feeling, mainly with the two questions you see that, so around trust on the new COVID-19 vaccine and also how important it is for people to the vaccine itself. Next slide, please. The other domain is social processes, mainly assessing whether there is a prevalent positive social norm amongst the respondents or not. Next one, please. The third area is the motivation, so whether people are willing to uptake the vaccine when it becomes available to them. And the last one, next slide please, is practical issues. So whether it was easy for those willing to get the vaccine to actually get the vaccine. And these, as I was saying, provide us a very interesting 360, let's say, vision of the different drivers that are influencing vaccine demand and uptake. We started with health workers because they were our first target in the region. Then we adapted the tool for teachers, general population, and now we are using for youth. So in this idea of bringing additional data to complement what we already had to really ensure that the programmatic recommendations we were proposing to governments were adequate and were tailored, we were using the dashboard. Next slide, please. So the first, next one, yes, thank you. The first one, area that I think to us was very relevant in terms of advocacy, both internal within UNICEF with other colleagues that are not at ease with the demand component, but also external to donors and the governments and partners, was to see these information from the dashboard on what were the reasons driving vaccine hesitancy in our region. And the first reason, as you are seeing, it was the concerns about side effects. The second one was on safety, and the third one on effectiveness. And this is something that came out, has been coming out, not only through the BESD, the Behavioral and Social Drivers tool, but also through our online social listening. So it was very nice to see that we had this alignment, and there the narrative started changing in the sense that you can actually address these concerns, providing different channels, communication channels, and also community-based interventions. Next one. The most interesting part for me on the dashboard, it was actually triangulating these two information that the dashboard contained and that we were not capturing on our data. The first one was the percentage of unvaccinated participants that actually tried to get the vaccine. And this is very important in a context in which access to vaccines and access to the health facility itself remains a huge challenge. So when you have a narrative saying that the problem is hesitancy, but actually you see, for example, in South Africa, you have 12% of the people that tried to get the vaccine but were not able to, then you start programming differently, correct? And we triangulated these with the other information on what were the structural barriers reported by those who were unvaccinated. And of course, you have issues around vaccine appointments. Imagine in countries in which access to internet is not easy, in which not everybody has a cell phone, in which access to health facilities is difficult. It's very complicated to get an appointment. The other one is the difficulty traveling to site, which points again at this problems around accessibility. And the last one is the difficulties they were having to leave work or school, which talks about the non-adaptation of service provision to the demand needs, to the lifestyle of people. Next slide. We find the same, for example, the previous one was for South Africa, but in Kenya, we find very similar data. Like, for example, in the case of Kenya, is 19% of those who wanted to get the vaccine were not able to do it. And again, the reasons are the same, is the difficulties getting appointments, is the difficulties traveling to the sites, and the difficulties adjusting their work style or their lifestyle to the opening hours of the vaccination facilities. So this was for us, let's say, a trampoline or something that we really leverage at many levels to request, first of all, a facilitation in terms of appointments and how to access the vaccine. But we are also, for example, advocating for measures at country levels to be taken, either to subsidize transport to access facilities or to move the vaccination points to places where people were gathering, like markets or churches. And in this line, we started working, for example, with Association of Religious Leaders so that they could offer their spaces as a vaccination site. And finally, we have been advocating for longer hours of vaccination so that people that need to take care of their family and works could actually benefit from the vaccination. I think this is it, but you can move just to check. Yes, so this is it. Thank you so much for John Hopkins teams. This has been a fantastic tool for us. Thank you very much.
Thanks so much, Helena. That was fascinating. And I thought I heard you say that the dashboard was a trampoline. I hope that's true, because that's a term that I intend to incorporate. Very interesting. And I see questions are starting to come in, and just remind people to please put them in the Q&A box, and we'll get to them as we go along, or we can address them in the Q&A session towards the end. So now I'm going to go to our next presenter. It's my pleasure to introduce Tom Black. Tom works on the Insights team of the Gates Foundation's Global Delivery Program. This means that he helps design, run, analyze, and report on research projects that include understanding people's attitudes and behaviors related to COVID-19 vaccines. Now, prior to joining Bill and Melinda Gates Foundation, Tom worked as a pollster in London, working on national, local, and European elections for parties of all political stripes. I don't think he's going to be able to answer questions about polls, but he will answer questions about COVID-19. So he's based in Washington, D.C. Tom, welcome.
Yeah, thanks, Anton. Yeah, I will stay away from any political polling discussion during this webinar. So I'm Tom, I work at the Gates Foundation. I'm going to show two different use cases. If you could just skip the slide onto the first one. There are more, but I think these are pretty illustrative of the kinds of things that we do with this kind of data. So the first is represented by these rather natty screenshots on the right-hand side. We have a set of priority countries within the foundation where we're focusing on much of our COVID vaccine delivery and uptake work. And we're trying to aggregate all of the relevant vaccine willingness data in these countries that we can get our hands on. And the chart at the top is where you can see how these data have been aggregated into trend lines over time for each of these countries, tracking what we have in terms of willingness. And the COVID behaviors data is obviously a crucial input into that aggregation, as are other sources like the collective service dashboard, some of the UNICEF data that Helena was referencing before. But the CCP data is, for many of the countries that we're most interested in, one of the only time series data that we have. So it's a crucial input into that. And without it, many of these error bars would be very large, and crucially, the gaps between the different intervals would be even larger. But I think more usefully is the disaggregation of these data, which is shown by the one on the bottom of the slide. you can see this obviously shows the trend over time, but splits out the different sources that go into that. And the one that's sort of covered by a red bubble is the CCP data. This not only gives us info on how things are changing, but it also shows us how things are differing over method. You can see how some of the lines are fairly static and some of them change over time. And I think trying to understand the dynamics of the willingness data is crucial, because it actually helps inform funding decisions and programmatic decisions in each of those countries. I think the other thing, it also, as I would reiterate what Helena was saying, it helps us to put demand into its right context, and as I think you said, change the narrative on what hesitancy means in this context, the importance of other structural access barriers, and sort of push back a little bit on this sense that it's hesitancy which is the big problem here, and help to recontextualize that and give us some more useful, more comprehensive understanding. And the next slide, if you can click on to one, shows probably a more practical example, and I should credit my colleague Jeff Pituch. This is his work that I'm going to show here. It shows how we use the data sort of less as an input into our own analysis and more as a kind of corroboration or investigatory tool to assess trends we're seeing in other data. So the table on the left shows how in mid-October, I think this was, Mozambique and Angola were some of the most efficient countries at translating supply of the vaccines into administered. And obviously there's a lot that goes into that, but one component of that is demand, is willingness for the vaccine. And so we use the COVID behaviors data to assess, where were these two countries differentiating themselves from others in sub-Saharan Africa in terms of population perceptions of the vaccines. And there were two obvious standouts from the data. The first, which is that chart at the top there, was showing higher levels of perceived risk from COVID infection in each of those countries, much higher in many cases. And obviously, that translating into higher levels of willingness too. And the second, which again, I think will be familiar to lots of people, higher levels relatively of trust in local health workers, global health organizations, the political actors. And again, that translating, we think, into a more comprehensive and sort of better demand scenario. I think what's crucial here is not that trust in authorities or institutions is important, or COVID perception risk is important. I mean, of course they are, and everyone knows that. But what it means is that because we have other countries here, we can use the same data set to assess where exemplar or outstanding countries are versus other countries that may be lagging or maybe less efficient, and start to use that comparative data to assess how much of a role the demand context is playing in that very complicated, as Helena's presentation referenced, very complicated transition from throughput to actual vaccines being administered. And again, the fact that this is sort of near real time means that changes in that are also obvious to us and become really crucial to understand again how demand plays a role in the administration of the vaccines. I think the two components of this data set that are so valuable in my work have been the time series quality and the cross-national comparisons. And I know, and Dominic and the team, we've talked about the sampling challenges of Facebook, particularly in many of the countries that we're illustrating here. But I think there are ways to mitigate that, and the benefits of the near real-time data, the cross-country comparability, the time series that you then get from that really more than outweighs those sampling challenges, and it fills an enormous gap in knowledge for us. So I also add my thanks to the team for doing this work and for sharing it so broadly. And that's it for me.
Okay, I have found my mute button. Sorry, it's just been 2 years since I've been all virtual, so just give me time and I'll get the technology right. Thank you so much, Tom. That was fascinating. I was actually looking at your screen, and that's why I had trouble finding the mute button. But thank you for a great presentation. Some interesting stuff there. So I'm going to move to our next presenter. It's my pleasure to introduce Cathy Church-Balin. Cathy has over 30 years of experience in health communication. She's currently the Senior Advisor Country Representative for the Johns Hopkins Center for Communication Program in the Philippines. In her position, she oversees the development and implementation of social and behavior change programs in family planning and COVID-19. Cathy, welcome.
Hi, everybody. Thank you very much, Anton. First slide, please. So I'm going to talk a little bit today about how we're using the COVID behaviors dashboard data in the Philippines. Just get started next. So just to give you some context, right now to date, there's been about 2 million cases of COVID, 2.8. I should say the Philippines is a country of around 110 million people. We're over hanging out under China, kind of next to some other countries that are all very political right now. And so far, as of today, there are 48,545 deaths recorded, and approximately 100 million doses of vaccine have been given out. Probably around 35% of the public is covered. We've just ended a series of national vaccination days that have been very successful. Some of you may know the Philippines as the home of the longest lockdown in the world. Our kids are still not back in school face-to-face around the country. There's a pilot going on right now. Most people are still working from home, and our travel restrictions are easing, but they're still pretty restrictive. So given that context, we've been working on COVID since March of 2020. And our next slide, please. So I wanted just to go over how we're using the dashboard. We've been using the dashboard data as long as it has existed. And there's really 4 main ways. One, we inform our partners about what's happening on the behavior front. We supplement other data sources, as others have talked about. We certainly use it to inform our campaigns and strategies. And we provide a resource to journalists, students, and other people. And that has really been a valuable resource to us. And I should put it in context that the data is, to us, it's pretty reliable because we get about 19,000 responses in each cycle, and about 89 million people in the Philippines are on Facebook. It's the overwhelming social media platform here. So we are feeling that a lot of people probably are being asked to complete the survey, and they do so. Next, please. So the first thing is there's a meeting here every Tuesday morning of all the USAID implementing partners, and we present the new data as it comes out. And we've picked a couple of key indicators in the dashboard that we are following over time. So one of them is, what are the topics people want more information about? And every time a new series comes out, we compare it to the one that came out at the end of August. And we let people know what are people thinking? What are those changes? And there are certain topics that USAID wants us to follow, and we use this to kind of keep track of those topics. But it's interest in the vaccine, interest in variants, interest in economics. So we follow this very closely. Next slide. And of course, we want to know who is willing to accept a vaccine. And it's really interesting here that over time, there have been some changes, and we've been watching this pretty closely. Older people are still our most resistant audience, but other audiences are quite open to vaccination. And we want to encourage that. And I use this to encourage people to frame their messages in a very positive ideation kind of framework, letting people know that hesitancy is going down as supply goes up. And that's an important thing to keep in mind. So we do follow this, and we report this out every time there's new data. Next slide. So we use this and we compare it to other data sources. So another activity of the Breakthrough Action work is we've hired this great firm that does really in-depth social listening, and we get a report from them every 2 weeks. And it just so happens to coincide with the same time frame as the COVID dashboards data. So I have this great intern, and he goes through and he compares. And he just wants to see if the social listening data and the COVID dashboard data kind of are in sync or where they're different. And we look at those differences, and we look at that to see to judge kind of the quality of both sources. They generally track each other very nicely. So that's something that we do because we have that ability. Next slide. We also are using it, really, that's what, what I care about the most, is to inform our campaigns and strategies. So one observation, the troubling trends of seniors resisting vaccination. For a while, everyone thought women were resisting, but we watched over time as more vaccine became available, men and women the genders were kind of equaling out. Urban, rural, not as big a deal, but age and those, what we're calling the stubborn seniors, it's still persisting. And so as we create new campaigns and messages, we are targeting seniors, but also the people who support seniors. So we can look at the other data that say, why, did you have a problem getting a vaccine? Did you not get the vaccine you wanted? But we can also target the people who influence our seniors and could, obviously maybe help them get to the vaccine. So we are keeping an eye on that. And unfortunately, that bubble keeps growing over time. Next. The other one that I'm watching very carefully is this high level of fear. So we've watched this over time, and I gave you a screenshot here from August where we had just gone into lockdown. Here that's called ECQ, and that's the most restrictive lockdown. And you can see that fear was very high. And over time, if you were to look at today's, things have loosened up here a little bit, and that fear is lessening, but it's still fairly high. And so, if we look at our theories, our communication theories about using fear and EPPM, we think about that. And we know that when people are very fearful, often they freeze and they don't act. So we want to bring up their efficacy. And so we're starting a campaign that's really is geared to putting people in what I'm calling the prevention mindset. And saying, okay, as we go back out, I hate to use the word normal. I don't want to use that in any of our work, but as we go back out to work and to school and to do the things we want to do, how can we do so carefully? How can we give people the efficacy they need to feel like they can resume their activities safely? And so that's this, again, we watch this indicator very closely. And we'll keep an eye on it as this campaign rolls out. Next, please. So here, this is my favorite graphic. This is, the what are people thinking about? So we're using this because it helps us know what we're going to talk about. We're also supporting the Department of Health here in their PR efforts. We're creating campaigns. We're doing a ton of social media. So we use this to kind of help us gauge what people are thinking about. And USAID is very interested in children's education, children going back to school. So we've been following that closely. Next slide. And what I like is you can drill down into any one of those bigger bubbles and you can see who's thinking about it. Well, obviously the older people aren't thinking that much about back to school, but parents, people who are parents' age, are thinking about it. And it lets us know. And it's interesting that we've been watching this over time. It hasn't moved hardly at all since August. And some donors are kind of perplexed because they think people should be, pushing to get their kids back out to school. But because of that high fear, we don't see parents actually pushing all that hard. They're in favor when they feel that it will be safe for their kid to go back. So we keep using this to remind the donors that we have to, work with the parents when schools open to encourage them to send their kids back. Next slide. And the last thing is, we shared this with journalists. We sponsored a journalist training and we gave this as a great resource, obviously a great source of data. And then wouldn't you know, a couple of days later, we found ourselves in the paper. So we did get journalists, we give this data, I share it with students to really let them know that there's a place where they can go to get really, as everyone else has said, very timely data around what people are thinking about COVID. in the country. So yeah, we made it to the TV. I just happened to catch that one morning and it was pretty exciting. Next, and that's all I have. Thank you very much.
Thanks so much, Cathy. That was terrific. I want a copy of that graphic. I want to use it as my backdrop, and really delighted that that you got in the papers. And we've been watching Philippines closely because I know hesitancy has been an issue. And I noted your comment. I think what you said was hesitancy goes down as supply goes up. So love to hear more about that. Wish we had more time, but if we have time, I may ask you to comment more on that. Okay, so now it's my very great pleasure to introduce our last presenter for today, and that is Gustavo Berganza. Gustavo is a journalist and a sociologist, currently acting as a consultant in communication for Breakthrough Action in Guatemala City. Previously, he worked as Director of Strategic Communication in the former Presidential Commission for Attending the Emergency of COVID-19. He's currently a contributor to Asociación, an organization that studies mass communication methods and their impact on the public. So, Gustavo, welcome.
Hi, everybody. I'm very pleased to attend this webinar. And well, first of all, let me explain a little about the work that Breakthrough Action does in Guatemala. First of all, we are managing now a special program on COVID-19. It is funded by USAID, and obviously the main reason is try to attend the emergency of COVID-19 and to support healthy behaviors and first of all and mainly vaccination. Then we do that through trying to create appropriate communicative conditions, and this labor requires forging alliances with health workers, journalists, and religious and community leaders to spread information that helps people overcome hesitancy towards vaccine and to fight myths and disinformation. This is a country where I suppose that it's happening the same in yours. This is a country that has a very great incidence on Facebook. And in Facebook, this is the main source of this information, as it is in WhatsApp. We cannot monitor WhatsApp, but we know that in Facebook there is a lot of negative messages about COVID. For instance, the people says that the virus doesn't exist, that the virus is a creation of or the virus exists and it is a creation of big pharma in order to earn more money with vaccinations and that kind of stuff. And we have also the kind of people that says that if the virus is a punishment from God for our bad behavior. So we must deal with all these conflicting messages that complicate the work of health workers, and we are trying to create campaigns and giving them tools in order to fight this disinformation. We also offer workshops for journalists to train them on techniques to improve their coverage and on the pandemics and information on factual sources to create news stories. Our work has been mainly with workers in the provinces. I mean, people who has probably haven't had formal training in universities about journalism, and we also support journalists in the capital cities, suggesting them sources for create stories about vaccination. and to create a favorable mood in order to improve this phenomenon. Additionally, we design and disseminate campaigns in the national and local media on the need to adopt appropriate actions to avoid contagion. We have during the first part of the pandemic, we try to create awareness about the necessity to keep healthy behaviors in order to prevent contagion. That was during last year, and in this year, when vaccines arrived, we began to promote the necessity of vaccination as the only way to reduce the risk of serious illness and also death. So this is the work that we do in Guatemala, and we do it in two ways. We try to, as I said in the beginning, to create these alliances with community leaders, with opinion leaders mainly, because we know that their credibility helps to spread the correct messages about the virus and vaccination. And also we do we create these media campaigns with spots in TV, in social media, in radio, that are that have our messages to try to change behaviors. We have been very lucky to have in our latest campaign the help of the National Conference of Catholic Bishops, because they allow us to record them giving messages encouraging the population to vaccinate. So next, please. Next. So how do we use the COVID dashboard in Guatemala? In this context, first of all, where we have at least 22% people that says that have a tremendous distrust about vaccination, we need to empower them because the dashboard says that they are the third people that have more credibility in order to promote vaccination. So what we do is to try to promote their trust in themselves in order to be more assertive in their work. We also give them information about what are the main issues about the resistance to vaccination. As my predecessors have told, well, there are issues that come with myths, with disinformation, but there are also issues that come with the accessibility to the vaccination centers. So in that way, they can design strategies to address this resistance, this absence from the vaccination centers. As I told them, give us the dashboard give us a very interesting summary about the most common myths and disinformation about vaccines, and we complement this with the findings that we have collected from our journeys in the countryside. We have been making technical assistance missions to different provinces, and we have these community meetings with leaders, and we discuss with them what are their worries about our vaccination and about COVID, and we use this information of the dashboard to cross it with the information that we collect. So in that way, the health workers have a better grounding in order to address these hesitancies. Also, this dashboard, whenever we promote them, we promote it with the health workers, will help their efforts in educating and promoting the prevention of vaccination. We did a seminar in October where we present this dashboard, and precisely we explain to the health workers all the information that it has, and that can be used in order to enhance their work in fighting COVID. The second aspect is as a trustworthy source for journalists to cover public opinion trends about COVID-19 and attitudes toward vaccination. I mean, well, you know that journalists have a hungry for data. They love the stories that are based in numbers and in evidence. So that so what we do is to call their attentions to interesting data that the dashboard gives, especially about, as I told before, what are the reasons why the people is resistant about vaccination, and what are the difficulties that the people sees in the campaign of immunization. And I think that's it. Next. And thank you very much for your attention.
Thank you so much, Gustavo. That was fascinating, and love to speak with you more about addressing healthcare workers, since that's been a concern of ours, and I know of many people on this call. So I think now we're able to. I see we've gotten a number of questions in the Q&A chat, and some of these have been addressed. I see that several of the questions related to methodological issues. I think Kieran and Brian brought up questions, and someone else. So I think I'll turn to maybe Dominic first, if you can address. I know there were several different kinds of issues about representativeness, reaching marginalized populations, and also comparisons with other surveys.
Yeah.
Dominic, over to you.
Yeah, absolutely. Happy to answer this question and as best as I can. The other, earlier we heard either Anton or Cathy, I can't remember. Maybe it was Anton who was talking about the trade-off between time, or maybe it was Tom, I can't remember, timeliness, like kind of volume and questions that you can ask in the survey, as well as that representativeness, and how that kind of trade-off has been happening throughout COVID and the pandemic. We understand that these data are collected through Facebook, and that does limit our overall population that we can actually select a sample from. And we also realize that often leaves out those people who are most marginalized and poorest within the communities, because they may not have cell phone access, may not have, never mind if they do have cell phone access, are they actually on Facebook? So there are limitations to who actually provides data to this data set. What is part of the process are sampling weights. So detailed sampling weights have been calculated to correct for some of the differences between the sample in regards to the gender and the age categorization within each country. And so at the global level, when we're doing the country representations in the dashboard, those are all weighted statistics. One of the things is that the reason why you have fewer, and this is why you have fewer countries within the subnational dashboard, is because those are the only countries that have subnational level weights. So we have a pretty strict rule in this process. So any cell size, so when we present data for either men or women, different age groups. We make sure we maintain a cell size of 100 participants so that we can apply the sampling weights correctly. Also, but we do definitely recognize the limitations. And I think, I know I put in the response to Brian or another individual about how, COVID has provided us this opportunity to both, kind of dig into data and make decisions based on data. But through that process, I think anybody who's doing this work has got to be critical and really observant of how we're learning about these different platforms and what these different platforms for data collection are going to tell us over time, so that we can kind of not only address the pandemic right now, but for future activities. Being part of Breakthrough Action, we do a lot of work both through this Facebook survey, and we use this in our work a lot. Like Cathy's example is a great one, and is reflected in many of the Breakthrough Action countries. But also we do implement phone-based surveys implemented by different professional agencies and things like that. And we do juxtapose these data in different countries. It's important to recognize one data set is not going to solve this pandemic, and that the triangulation of data, like Helena talked about earlier, is really critical to success and making decisions and really informed decisions. So there are these limitations. You can find a lot more information about this on the methods tab within the dashboard. And that will provide some clarity, but you can also reach out to our team. There is a contact list at the bottom if you have more specific questions. And there are also journal articles that we can link you to that reflect the sampling weights development and even some critical articles of the data set. Because I think it's important to be, open to those conversations for sure. And this is a data utilization project, and we want people to use these data and understand the limitations to these data when they're applying them in their own projects and their activities. So thanks for that question.
Thanks, Dominic. I see a lot of questions have come in through the chat, and many have been answered, and I'm not sure if people want fuller answers, but there is, I'm going to turn to Cathy. I think there was an interesting question on, now I can't find the question, but it was on, well, you'll know, Cathy. This had to do with whether you're finding that traditional theories, have covered the data that you're seeing, or if anything new is emerging. And I'm sorry, I can't find the question and who's asked it, but it relates to, in my mind, it relates to what I noted from your presentation where you said you're seeing hesitancy going down as supply is going up. Just wonder if you could, if you know the question that I'm referring to, and if you could kindly address that.
And it's a good question. I can't say I'm a theorist by any means, but I use the theories, I rely on the theories that I've used and learned about over the last many years. I see them in effect. EPPM, I think we play with that one a lot. I've done work, in other places where we've looked at that balance of fear and efficacy. And I think you definitely see that here in a pandemic. When fear is very high, do people have efficacy, and how do you break through so they can start to engage in those preventive behaviors that are going to be, save their lives, make them safe. So I think we rely on that. And I bet, like I was saying, when this is over, not when it's over, but when we have time to sit back and look at it rather than working in the moment, I think we'll learn a lot when we go back. And we are going to do probably in about 6 months, we are going to try to do a really in-depth survey type evaluation. It's still being designed because we've been in a really interesting time. The Philippines is a really dynamic, very heavy mass media market. Everybody's on Facebook and other social media platforms. So we can really look and see, what does it mean when you have so much going on? How do you decide who your sources are going to be? How are we shifting from community-based sources to digital sources? So I think there's, probably a lot of PhDs can come out of the work that we're doing right now, but it's hard to know. I rely on EPPM and ideation, because those are the things that in the moment I want to tell people. So when you say to people, 90% of the people in your area have the vaccine, or 60% of the people are doing this. When people see that others are doing it, they want to do it too, or they feel more confident that they can be successful. And those things that are hard for everyone. So that's the thing we also, learned about, is acknowledging when certain things we're asking people are culturally or socially difficult, like distancing. In the Philippines, you don't walk down the street by yourself if you can avoid it. You're arm in arm with somebody all the time. So, when we ask people to be apart, that was a tough one. And it's something that we still struggle with. While masks were already a pretty accepted behavior here, people wore masks when they weren't feeling well. It came from SARS. So you would see people wearing masks on the street all the time. So more people wearing masks, not a problem. Having little kids wear masks in school is our new problem. So we're going to work on that next. But that wasn't the big one. So you have to kind of see what your culture and what's socially acceptable, and then work on those things that are not, and try to make sure that we look at this in a community and a collective way. And that's what we're doing here. But we are using social media like it's mass media. And so we're able to really put out information quickly. And we're working with the DOH to not just put out facts, but to put out motivation, to put out, those behavior drivers, looking at things through a behavioral economics lens or other lenses as well. So that
Thanks,
answers
Cathy.
the question.
And I think the dashboard's ability to separate out those different kinds of factors. There was a question for Tom about hesitancy, and one of the things I like about the dashboard is that it does allow you to separate the different factors that play into hesitancy. I see by the clock on the wall that we're just about out of time. Let's see, who's my time checker? Do we have time for one more question?
Yes.
Okay, I'm actually going to Maria's question for Gustavo, because I think misinformation has been such a hot topic of conversation. And Gustavo, I think we just have a couple of minutes, but if you can maybe say a little bit about how you're addressing the misinformation issue that we're getting through the social media in general, and if the dashboard has been helpful.
Well, first of all, what we do is that we elaborate a presentation about the myths about vaccination, and about the virus, and we share that with community leaders. We have shared also this with journalists in the provincials, in the provinces that we have visited in our tours of technical assistance. And it is really surprising the kind of if you say lack of knowledge about scientific facts about the vaccination and the pandemics. I mean, the people in the countryside in Guatemala is really a very fertile terrain for these myths to grow. So giving them this information that we have prepared has been very helpful, and also for the health workers, because they are really overburdened with the work that they are doing fighting the COVID, and they don't have time to think in creative strategies and doing research for getting information to fight this disinformation. So these things that the dashboard gives about what are the more common myths and what are the difficulties, gives them a very valuable feedback in order to promote vaccination and in the relations to inform the community leaders about this, and well, it is very valuable. And well, and finally, as it happens in Philippines, well, Facebook is Facebook, and secondly, WhatsApp are the main sources of this information. Unfortunately, we don't have access to the information that is spread in WhatsApp. And what we have done with this is to encourage the people in the different district areas of health in the provinces to create WhatsApp groups as well, where they can spread this information and also spread information that is based in the dashboard. So that's what we have done.
That's very good. Thank you so much, Gustavo.
Answer your question. Mm-hmm.
Social media is definitely a double-edged sword, and again, delighted that you are focusing on health workers, and as they have special needs and are very special resources for us in the response. I think our time is just about up, so I think I'm going to throw it over to Dominic for any last words and maybe to sign us off.
Thank you so much, Anton, and all the panelists. This has been really great. I think it's great for a lot of the audience too to see how these data have been used in different ways, and hopefully either inspire the integration of these data and other data into the work that they're doing, or just simply curiosity, or even curiosity around, you know, the decision. If you ever have questions about why we built the dashboard in the way that we did, you can shoot those over as well. But this has been great to kind of see the application of data across these humongous programs, and really impactful nature of these data, and also that triangulation piece. You know, I really appreciate the panelists taking the time today, and for everyone tuning in. This will be recorded and posted on our webpage. There's probably other things that I'm forgetting to say about this, but look for that, and please sign up for any. We do have signups on the dashboard for any newsletters or other things that are coming out. I know we just finished a technical brief that we're going to post either today or tomorrow, and y'all can receive that or download it from the webpage when it's available, focusing on some of the global trends around vaccine acceptance. So we'll be posting more of those in the next couple of weeks. So thank you again for tuning in, and really appreciate everybody's time today and all the insights. Thank you.